Okay, let's dive straight in then. Have you ever really stopped to consider how we decide what's best in healthcare? Not just for ourselves, I mean, but for everyone, for society as a whole. It sounds, pretty straightforward on the surface, but it's actually a surprisingly complex question. It really gets down to what we value. And today we're taking a deep dive into the science behind that, specifically how we measure these things called health state preferences. Think of it as a way researchers try to put a number on something deeply personal or values about health. Our main source for this is a really foundational paper from 1989. It's by Debra Froberg and Robert Kane. It's called Methodology for Measuring Health State Preferences, Measurement Strategies. And it's actually just the first part of a four-part series, so it really sets the stage for this whole field.
Yeah, it's fascinating stuff because what science is trying to do here is, well, it's trying to quantify something incredibly subjective, things like quality of life or how desirable a certain health situation is. Putting a number on that, that's the challenge. So our mission today is basically to walk you through the scientific strategies they came up with and hopefully shed some light on the key differences between them and, the difficulties involved.
Okay, let's make it relatable. Think about your own life, maybe decisions you've seen friends or family make, like a patient facing a really tough treatment. Maybe it extends their life, but the quality of that life, it drops significantly. That's a hard choice.
Or even simpler things, choosing health insurance, right? HMO, PPO.
Yeah.
You're weighing cost, freedom, maybe the doctors you can see. These are all preference choices driven by what you value most in that situation.
Right, and these personal choices scale up, don't they?
They absolutely do. If you look at the bigger picture, similar kinds of evaluations happen at the policy level all the time. Policymakers have these incredibly tough calls. Which programs get funded? Maybe it's community services for seniors versus, say, prenatal care for low-income women. Often there isn't enough money for everything. So how do they choose? Ultimately, all these decisions, from your own insurance to national policy, they hinge on what outcomes we decide we value.
And it's messy, right? It's not like choosing between apples and oranges sometimes. It's more complex. You're often treating one good thing for another. Like, okay, I'll accept these drug side effects because it lowers my stroke risk.
Exactly. It's always a trade-off.
Yeah.
And our values, they aren't set in stone. They can shift. Maybe something happens in your life or you learn something new and what you prioritize changes.
That makes sense.
And just to be really clear on terminology, because the paper makes this distinction, values are sort of these general beliefs, like being independent is important. Preferences or utilities, those are the terms we'll mostly use. They refer more to the specific satisfaction or desirability you feel about a particular health state.
Okay.
So how much better is walking with a cane compared to being bedridden? That difference is a preference or utility.
Got it. So it's more specific, sometimes called quality of life weights or ratings.
Exactly, or an index value. We're trying to get a cardinal value, a number that shows the magnitude of how much better or worse one state feels compared to another, not just ranking them.
So, okay, how on earth do researchers actually start measuring something this fuzzy, this subjective?
Well, the paper lays out sort of three general steps. It seems logical when you break it down. First, you need to define the set of health states you actually want to measure. What are we talking about? Second, you find your judges, the people who give you their opinions, individuals, groups, whoever's relevant. And third, sometimes you need to aggregate all those individual judgments to get some kind of overall scale value for the group.
Let's focus on that first step, defining the health states. That seems critical.
Absolutely foundational. You have to decide, what are the important dimensions of health here? And that really depends on why you're doing the research. What's the goal? But commonly, researchers look at things like, physical function, social function, emotional state, pain levels, cognitive ability, those kinds of domains.
Okay, but how many dimensions can you realistically include? I remember reading something about how our brains can only handle so much information at once.
That's a fantastic point. And the paper mentions this too, drawing on cognitive psychology. Yeah, the research generally shows humans can juggle about, 5 to 9 pieces of information simultaneously, maybe fewer reliably. So as a practical matter, when you're designing these health states for people to judge, you typically stick to 9 attributes or fewer, often less than that, really.
Right.
You want people to be able to grasp the whole picture without getting totally overwhelmed.
Right. So how do these attributes become actual health states people can rate?
Let's use a simple example like one from the paper. Imagine just 3 attributes: mobility, pain, and emotional well-being.
Okay.
And maybe each one has 4 levels. Mobility could go from no limitations down to does not walk. Pain from no pain to severe pain. Emotional state from not depressed to very depressed.
Makes sense.
So you create a specific health state by picking one level from each attribute, like walks with limitations,
Mm.
moderate pain, and mildly depressed. That's one unique state. In this little example with 4 levels for each of 3 attributes, that's 4 times 4 times 4.
64 potential states.
Exactly. 64 unique health states. And the goal is to get that cardinal value, that index score for each one.
Okay, so we have the states defined. Now, how do we actually get the measurements? You mentioned different strategies.
Right. And it's important to separate the measurement strategy from the scaling method. The strategy is the overall plan, how you ask the questions, how you analyze the results. The scaling method is the specific task the person does, like, putting a mark on a 0-100 scale or doing that time trade-off thing.
Got it. Strategy first.
Yeah. And broadly, there are 2 main strategies discussed: holistic and decomposed.
Let's start with holistic. That sounds like
Yeah.
looking at the whole thing at once.
Exactly. With a holistic strategy, the judge is presented with a description of the entire health state, all the attributes combined, and they just give an overall rating for that state. You're not asking them to think about the individual parts, just the overall picture.
Can you give an example of what that looks like in practice?
Sure. There was an early study, Sackett and Torrance in '78, where they wrote these really vivid, detailed scenarios. Like, the paper quotes part of their description for being on dialysis.
Yeah.
It goes something like, "You often feel tired and sluggish, tubing inserted into a vein, chronic discomfort. Must go to the hospital 2 or 3 times a week for about 8 hours on the machine. Many people become depressed."
Wow, that paints a picture.
Right, really detailed. And then judges would use something like the time trade-off method. Would you trade years of life to avoid this state? To put a value on that whole scenario.
And there are others too.
Yeah, another example mentions is Patrick et al. From '73. They had judges rate 400 different case descriptions. Things like 6, 17 years old, walked freely, traveled freely, couldn't do major activity but could do self-care, had cough, wheezing, or shortness of breath. Again, a whole package deal.
Okay, seems intuitive. You just react to the description. But what are the downsides? You mentioned limitations earlier.
There are some pretty significant ones, according to the paper. First big one. You often assume the scale values you get have equal intervals, meaning the difference between a rating of, say, 70 and 80 feels the same to the person as the difference between 20 and 30.
Right.
But with holistic methods, you can't actually test if that assumption is true. You just have to hope it is. Second, it doesn't tell you anything about how the person arrived at their rating. How did they weigh the mobility versus the pain versus the depression? In that dialysis example, you don't know. And finally, just practically, imagine rating 64 of those detailed scenarios, or 400. It's a massive burden on the judges, very time-consuming, potentially fatiguing.
Yeah, I can see that, which probably led to other approaches.
Exactly. That's where decomposed designs come in. Researchers needed something more efficient and something that could give more insight.
Okay, so decomposed designs, breaking it down, what does that look like?
Well, there are 2 main flavors here: explicitly decomposed and statistically inferred decomposed.
Let's take the first one. Explicitly decomposed, often called MAU, right? Multi-attribute utility.
That's the one. Here, instead of rating the whole health state, judges evaluate just one level of one attribute at a time. So you might rate how good or bad severe pain is, assuming everything else is, say, normal. Then you rate moderate pain, and so on.
Kind of like tasting individual ingredients before the whole dish.
Yeah, that's a decent analogy. You're trying to build the value of the whole state from the values of its parts.
But that sounds like it involves some assumptions, too, about how the parts combine.
Big time. MAU models rely heavily on what are called independence assumptions. Things like utility independence or additive independence. But basically, does your preference for a certain level of, say, physical function change depending on your level of mental health?
Ah, okay. Like, does being pain-free feel even better if you're also perfectly mobile compared to if you were bedridden?
Exactly. If those things interact, the simple additive models don't work, or they get much more complex. And the paper notes that actually testing these independence assumptions is really hard work. Tedious, exacting, and time-consuming, often just not practical for large studies.
So what do researchers do?
Sometimes they just have to assume independence holds, like Torrance and colleagues did in a study on neonatal intensive care mentioned in the paper. It's a practical shortcut, but it's still an assumption.
Okay, so MAU is more efficient than holistic, fewer judgments needed, but it still has this validation issue. You can't easily confirm the model or the weights.
Precisely. It's more efficient, but you still don't get that empirical check on whether the model truly reflects how people think or if the underlying utility scales are really valid.
Which brings us to the other type, statistically inferred decomposed models.
Right, and this is where the paper really highlights an approach called functional measurement,
Okay, this sounds important. Why is this one potentially better?
because it's designed specifically to tackle those validation problems we just talked about head on. It comes from work by Norman Anderson back in the 70s. The core idea is brilliant. You design the experiment so that you can simultaneously test your theory about how people combine information and measure their subjective values on validated scales.
Simultaneously, how does that work?
Think of it like this. Information about a health state, like severe depression or no physical limits, comes into your brain as subjective values.
Yeah.
Your brain uses some kind of combination rule, maybe addition, maybe averaging, maybe something more complex to integrate them.
Okay.
That integration leads to an overall subjective feeling, which then gets expressed as your rating on a scale.
Yeah.
Functional measurement tries to mathematically unpack that whole process. It aims to figure out what are the subjective values of the inputs, what's the combination rule, and what's the value of the final subjective response. And critically, it does this in a way that validates that the scales have equal intervals.
Wow. How do they actually do that in an experiment?
The key is using a factorial design. Remember our simple example with mobility, pain, and emotion, each with levels.
Yeah, 4 by 4 by 4 gives 64 states.
In a factorial design, you'd systematically create states that represent all possible combinations of the levels across attributes.
So, no mobility limits combined with no pain and not depressed. Then, no mobility limits with no pain but mildly depressed, and so on.
Exactly. You create all or a carefully chosen fraction of those combinations. Then judges rate each of these specific combinations.
And then you analyze the ratings.
Yes, using analysis of variance or ANOVA. And here's the really clever part.
Okay.
If the way people combine the information is simple addition, meaning the effect of pain just adds to the effect of mobility impairment, without interacting, then when you plot the results, you should see parallel lines.
Parallel lines, what does that mean?
Imagine plotting the average rating for different levels of pain, with separate lines for each level of mobility. If those lines are parallel, it tells you that the impact of increasing pain is the same, regardless of your mobility level. There's no interaction effect.
Ah, I see.
And crucially, Anderson showed that finding this parallelism simultaneously validates two things. One, that an additive model is the correct psychological rule people are using. And two, that the response scale that judges used has true equal interval properties.
What's huge? So it's not just an assumption anymore.
Exactly. It's an empirical finding.
Right.
No other method discussed provides this kind of joint empirical validation of both the psychological process and the measurement scale itself. That's why the paper argues it's technically superior.
Okay, that sounds really powerful. Are there downsides? Practical challenges?
Sure. With many attributes and levels, a full factorial design can create a huge number of states to rate. Though, as mentioned, you can sometimes use fractional designs to reduce that load.
Sure.
And it definitely requires expertise. You need to know how to design these experiments properly and how to run and interpret the ANOVATE statistics. It's not trivial.
Has it been used much in health research?
Oh, yes. The paper cites examples. Vate and colleagues used it and actually found interactions between physical and mental health, suggesting a simple additive model wasn't quite right there. But Cadman and Goldsmith, evaluating programs for handicapped children, did find an additive model fit well across 8 attributes. So it can reveal different combination rules depending on the context. It's flexible.
What about other statistical approaches? The paper mentions multiple regression briefly.
It does. Multiple regression is sometimes used. You get ratings for multi-attribute states and then use regression to estimate the weight or importance of each attribute.
Sounds reasonable.
But here's the catch, and it's a big one compared to functional measurement. Regression assumes the scale values you feed into it are valid interval scales. It doesn't test that assumption. You might get a high R-squared value, suggesting your model fits the data well. But that doesn't prove the underlying scale is valid, or that there aren't important interactions you're missing. Functional measurement directly tests those things.
So wrapping up this section on measurement strategies, if you're the learner trying to grasp this, what's the main takeaway?
The main takeaway is that while different methods exist, functional measurement stands out from a technical perspective. Its unique strength is that ability to simultaneously validate the psychological process, how people combine information, and the measurement scale itself, ensuring it have those crucial equal interval properties. That gives you much more confidence in the results.
But even with the best method, we still have that cognitive limit, right? Don't overwhelm the judge.
Absolutely. The paper reiterates that advice. Probably best to stick to 9 attributes or fewer when asking for these multi-attribute judgments. Keep it manageable, keep it reliable.
Okay, that makes sense for measuring individual preferences really well. But here's a big question that comes to my mind. Even if we get perfect measurements from individuals, how do we use that information for a whole group?
Yeah.
For society? You might think, well, it's simple, right? Just average everyone's preference scores together. Done.
If only it were that simple. This is where things get really thorny and where social choice theory throws a major wrench in the works. The paper brings up Kenneth Arrow's famous impossibility theorem from 1951.
Okay, Arrow's theorem. What's the gist?
The gist is pretty profound. Arrow proved mathematically that if you have individuals ranking 3 or more options, there's no method, no voting system, no aggregation rule that can combine those individual rankings into a single, consistent group ranking while also satisfying a few basic, reasonable conditions of fairness and rationality.
No perfect way to aggregate simple rankings.
Basically, yeah.
Okay.
It shows that translating individual preferences into a collective will of the people is fundamentally problematic, mathematically speaking.
Okay, but Arrow was talking about rankings, right? Like option A is better than B, B is better than C. We've been talking about getting cardinal utilities, those interval scale numbers that show the magnitude of preference. Does that help?
It potentially helps with the pure aggregation mechanics. If you have cardinal numbers, you can average them, mathematically speaking. But T, and this is a huge philosophical base, but doing so requires something called interpersonal comparison of utility. Meaning you have to assume that my 10 units of happiness from being pain-free is directly comparable, even equivalent, to your 10 units of happiness from the same state.
Can we really assume my subjective experience is the same as yours just because we both put the same number on a scale?
That is the million-dollar question. It's a massive philosophical debate with no easy answer. Can we truly compare subjective satisfaction across different people?
So how do researchers or policymakers even try to deal with this in practice?
They try different things, none perfect. The paper mentions some approaches. Some researchers try to recalibrate individual scales to make them more comparable. Others, like Torrance did, set common anchor points. For example, defining perfect health as a utility of 1 and death as 0 for everyone, and assuming the difference between those states represents the same amount of utility for all individuals.
Okay. An attempt at standardization.
It's an attempt. But think about the equity implications, which the paper touches on. Let's say you have a health state. 3 people rated at 20 utility points each. The average is 20. Now imagine another scenario. 2 people rate it at 30 points, but 1 person rates it at 0 points. The average is still 20.
Right. Same average, very different distribution of well-being.
Exactly. Is that equitable? Does the average tell the whole story? It's not just numbers. It's about fairness, distribution, whose preferences count, and how much. These aggregation methods have real consequences for who benefits from healthcare decisions.
So that's definitely something for you, the listener, to really chew on. How much can we truly capture a social preference by combining individual feelings? And what vital nuances, what individual experiences might get lost when we try to average everything out? So let's recap this deep dive. We've really journeyed into the complex world of measuring health state preferences. We started with the basic building blocks defining health states based on attributes. Then we looked at the different strategies, the intuitive but limited holistic approach.
Yeah, the move towards decomposed methods, like MAU, with its efficiency but tricky assumptions.
Culminating in functional measurement, which offers that powerful simultaneous validation of the scales in the process.
And maybe the final thought to leave you with, drawing on all this. The next time you hear about healthcare policy, maybe funding a new drug, deciding between different public health programs, try to think beyond just the outcome. Ask yourself, how did they figure out the value of those outcomes? How are people's preferences measured? What assumptions went into combining those individual views into a collective decision? Because understanding that hidden process, those measurement choices, gives you a much deeper insight into why certain decisions get made.
Absolutely, it adds a whole new layer. Thank you so much for joining us on this deep dive into the really fascinating and definitely challenging science behind healthcare values and decisions. We hope it sparked some curiosity.